Children born with congenital heart disease grow up to be adults with congenital heart disease, and far more of them are indeed reaching adulthood, where they need some specialized services. And so we're talking with Dr. Robert M. Campbell, who is Chief of Cardiac Services, Director of Sibley Heart Center, Cardiology, and Emory University School of Medicine, Sibley Heart Center in Atlanta. First off, thank you for some time. We're here at the Cardiovascular Summit in Las Vegas, and you're here with a group that the ACC has proudly developed in the last few years. Can you tell me about the ACPC?
The Adult Congenital Pediatric Cardiology section now represents a ever-growing population of cardiology patients that were born with congenital heart defects years ago. When I started my fellowship 30 years ago, many of them didn't have surgical options. Many of them didn't survive surgery. Many of them didn't survive to adulthood. That's all changed within the past 30 years. Now most patients will survive. We really have to address this issue of a growing population. It's estimated that very shortly there'll probably be more people in the United States as adults with congenital heart defects than there will be kids.
Here at this particular meeting, which is kind of thriving at a time of change, what are the issues you're addressing?
I think one of the biggest issues, just as we heard at one of the first sessions here, is about reimbursement and about value, about quality. In the world of adult cardiology, let's imagine there are 100 patients. They're relatively homogeneous. They have coronary artery disease. These patients have similar disease processes that are causing them to be sick. In pediatric cardiology with congenital heart defects, there's a huge spectrum. Our volume is lower, the patient much more heterogeneous. And so when it comes down to having evidence-based physician performance measures for quality and outcomes, that's not what pediatric cardiology is about. We don't have those evidence-based measures. It seems somewhat daunting and scary to me as a section chief and as a physician that we may end up without the quality measures that we have. We won't be able to talk about value. We won't be able to demonstrate best practices or outcomes because we haven't sat down really as a profession to define it. When we try to do it even in a big center like ours in Atlanta, single volume, we really don't have enough volume to make statistical assessment of best outcomes and best practices. So what we really need to do is begin to think about this as a profession around the country, pool our data so that we can define what's best, what's quality, what's value. So when it comes time to saying, how do we justify who we are and preserve what we do for our patients, how are we going to stay in business?
And this program really developed, I think, in 2004. So is this kind of the answer that you're looking for in terms of coming up with some of these answers?
Well, there are lots of different little groups. We're a pediatric cardiology and adult congenital heart disease. We're a very small fraction of the ACC. We'd be a very small piece of AHA. Pediatric cardiology is a very small portion of what goes on with the American Academy of Pediatrics. So we really don't have a home. We don't have a home for who we are. Okay. So that's one thing we're trying to do, to say if you could get section chiefs and administrative partners to be at one meeting and talk about what they have in common and what we need to do collectively rather than continue to try to do things on our own, I think it would be to our benefit. It's going to benefit us, and therefore it's really going to benefit our patients.
I mean, the issues that are being addressed across cardiology are going to be impacting you in any number of different ways. Is this going, how are you surviving 2013, I guess?
Well, I think still this is strictly my perspective, I think it's 2013 is continuation of 2012, which is tried to, if you will, the quote that was used in the most recent session was that burning platform. What's the burning platform for us to work together? And the real concern is to say that if we're going to define who we are proactively ourselves, and if we're going to define quality, we need to start doing that now, or else we'll be in a reactive mode when somebody else comes back and says, well, if you can't prove you're good, or if you haven't defined it, we'll define it for you. Now we're in a reactive mode without any data, and that's a terrible place to be. Our patients won't benefit from that, and our profession won't benefit from that. We really need to get people to start talking together. We really need to start saying, how do we solve this problem together? What's the best that we collectively can do? Physicians as a group, I've always said, are very competitive. We've been trained for that. We've been selected for that. We're very good at competing. Fine. Let's collect our data, have a national data set, best outcomes, best practices. What's the best we can do? If we want to compete, go home and compete against the national data.
So out of the few dozen of you that are here at this meeting, what's your goal when you walk away from here?
I think a lot of my goal, being a member of the director of the clinical practice work group within the ACPC section, is basically awareness. Just, here's a group, here's a forum around which we could meet, get more people to come, to think it's worth their time, to show it's worth their investment of their time and their effort and their energy, and how we can begin to ask what are those important questions that we need to address collectively as a group and figure out how we're going to do that. And
you have a site on CardioSource, correct?
Yes.
So if you're an ACC member, or even if you're not, you can go to CardioSource and you're searching for the Adult Congenital and Pediatric Cardiology section that was established in 2004. For CardioSource World News, I'm Rick McGuire.